Ki67 is another staining test that's done in pathology labs. And it's basically a test of proliferation. Is the cancer growing more rapidly or have a little bit more turnover, or is it more kind of sleepy and slow growing? And you might think, well, that's really important information to know. Although we do get some of that through some of the other features that we learn from the pathologist, like the tumor grade. Ki67 is a little bit of a tricky marker, and part of it is that it's a little hard to run that test in a pathology lab. There have been these studies done where they ask 7 different pathologists to score Ki67. They'll give them the slides and they say, look at these slides independently, give me your score. And the scores are all over the map. It's not a very precise and consistent test. There are international guidelines that were recently published to try to have all pathologists do it the same way and try to be more consistent. But cancer centers argue a lot about whether it's important because it can be so inaccurate. Ki67 has become more in the news recently because we did have a drug approval about 1.5 years ago for one of the CDK4/6 inhibitors, abemaciclib, that was built, or the approval included Ki67 as part of the approval language. This was a controversial move from the FDA, partially because the trial data for that approval wasn't restricted to Ki67. Like, the drug helped people who had high and low, and it wasn't limited by Ki67. But also people pushed back and said, this is not an accurate test. It's not routinely done in all pathology labs. And so I'll tell you at Dana-Farber, we do not do Ki67 because we just find it's too inaccurate, and we do not use it in our treatment decision-making. So, I would describe it as an extra piece of information. It's not something that all treatment decisions and all thoughts about the cancer hinge on. But sometimes we might use it when we're thinking about adding the abemaciclib, as I alluded to.
Great, thank you.